Hello, I'm Manoj Karmakar. In this next video, Professor Per-Arne Lönnqvist from the Karolinska University in Stockholm, Sweden, is going to present his arguments for the motion that thoracic paravertebral block should be the technique of choice for unilateral pain or surgical procedures on the thorax. If you're enjoying our videos, do remember to like and share these videos with your friends and colleagues. If you still haven't subscribed, do remember to subscribe to ISSPS TV so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
So I have been invited to speak in favor of the thoracic paravertebral block in a clinical context, and I will shamelessly do so. This is about unilateral things, but I would just like to remind you that you can, in fact, use bilateral thoracic paravertebral blocks, as Dr. Bozart told you in the previous lecture. And if you want to learn more about that, you can look at this review article in British Journal of Anesthesia. Second, I have a disclaimer, and that is that I'm a healthy skeptic to many of the new fashion plain blocks. And you can read the conclusion there. And together with Manoj, I have published two papers, an editorial and also a daring discourse, where I discuss the pros and cons of regular peripheral nerve blocks and these new fascial plain blocks. So you should bear that in mind. Okay, we will start with a little bit of history, and the first wave of enthusiasm when it comes to paravertebral blocks was in the early 1900s, where Hugo Sellheim and Arthur Levin in Germany first discovered this paravertebral block technique, and it is said to be first used for surgical anesthesia in 1919 by Capis. So it was very popular during the tuberculosis era, where you have thoracoplasties and that kind of thoracic surgery, but as other anesthetic techniques evolved, it went into this sleeping beauty period, as we heard about. And Dr. Bozart already has mentioned this seminal paper by Eason and Wyatt calling for a reappraisal of the technique in 1979. And then there's a few of us, the disciples, that have tried to spread the gospels through the years. And I would also like to remind you that it is now the 25th anniversary of this very illustrious medical society, the International Paravertebral Society, that unfortunately rapidly became the smallest medical society in the world because Sebenathan unfortunately had a coronary and died. So if you want to join, please let me know. So why did I bother you with history? And that is to tell you that it's more than 100 years old, this blocking technique, so it has passed the test of time. And it's an older technique even compared to epidurals. And as Dr. Bozart kindly said, it's now well established and widely practiced. So I think that there is a big good reason for you to use this. The other thing that I would like to do is puncturing the pneumothorax balloon. You heard previously Manoj Karmakar telling you about the frequency of inadvertent pleural punctures and pneumothoraces. And I have myself been part of two studies looking at this. The first one with the landmark-based loss of resistance technique. And then we found a 0.5% incidence. We also looked at the nerve stimulator guided technique together with the Soher in Lebanon, and we found the same, a 0.5% incidence with very, very rare need of putting in a chest tube and using suction. So that is a very rare complication. And as you heard from Manoj, he has used the ultrasound-guided techniques in thousands of patients, and so also the Danish group with Nielsen, and there is no pneumothorax. So I think that there is, we should stop talking about this as some sort of threshold to use paravertebral blocks, especially when we have ultrasound guidance. Okay, let's go to the core topic of the lecture, and that is the unilateral various procedures, and one is the posterolateral thoracotomy. And to save myself time and energy, I went to the European Society of Regional Anesthesia, where they have this procedure-specific postoperative pain management guidelines, the prospect. And the prospect guidelines for this type of surgical intervention, then they suggest that the paravertebral block and continuous infusion is the first-hand choice for good analgesia, but also lower complication rate, as Dr. Bolsart alluded to in the previous talk. And this is a grade of recommendation A. Also, the use of thoracic epidurals are good, especially if you use epidural opioids. So, but paravertebral blocks is the first recommendation of the prospect group. And what type of complications do you see? Well, you do see an increased number of pulmonary complications. You also see increased postoperative nausea and vomiting. You see an increased rate of urinary retention, but also, as we heard in the previous lecture, there is this issue of blood pressure and hemodynamic stability. And that is then in this prospective randomized controlled trial by the Admir Hadzic group, showing that you have less complications, hemodynamic complications, and you need smaller volumes of colloids and vasopressors. Also, Richardson and Sebanathan and others quite some time ago looked at what happens to post-operative thoracotomy neuralgia. And they looked at 1,000 consecutive thoracotomies in their practice in Bradford, and they could show that resecting a rib for access, then reducing the surgical trauma, and continuous paravertebral analgesia and non-steroidal anti-inflammatory drugs, in fact, could reduce this. So I think that paravertebral analgesia do have some specific characteristics that you can make use of. If you then go on to oncological breast surgery, I know that this will be discussed the next webinar session. And again, looking at the prospect recommendations that were published in Anesthesia last year, you can see that they obviously advocate the use of all these multimodal components, but also say that paravertebral block is recommended as the first choice region anesthetic technique. They go on and state that the pectoral nerve blocks may be of use and even local anesthetic infiltration. And since the prospect guidelines are based on a very thorough literature search and the more or less meta-analysis process, I think that these guidelines are very useful and adequate. As with looking at the thoracotomy patients, you can also have some nice preventive effects regarding long-term pain, as Cairo Lohmann and co-workers have shown, where they could show that the women that had paravertebral block instead of morphine post-operatively for pain relief had reduced prevalence of pain symptoms at the 12-month follow-up. So again, you can maybe influence the risk of having chronic problems after your surgery if you use the paravertebral approach. If we then switch over from oncologic breast surgery to non-oncologic breast surgery, there has been two very nice recent prospective randomized trials from Ilfels group. And this first one, then published this year from Gabriel, could show that the serratus anterior plane block versus paravertebral nerve blocks in fact came out inferior. This was designed as a non-inferiority study, but in fact, as you can see in the conclusions, serratus blocks provide inferior analgesia compared with the paravertebral blocks. These are the results, and you can clearly see that the median pain scores in the recovery room are very low in the paravertebral group and substantially higher in the serratus anterior plane block. But something that caught my eye is that if you arrive in the recovery room or soon thereafter develop a pain score of 5 or more, then I would suggest that you have a failed block. And if you then agree with this definition, you can see that There are 5 out of 50 blocks in the paravertebral group, but there are 15 in the serratus anterior plane block that could then be defined as block failures, which is about 30%. So I think that kind of is something that you should bear in mind. Here is the other publication from the Ilfeld group by Swisher, who compared the erector spine block with the paravertebral nerve block, also having 50 patients in each group, prospectively randomized. And they could again show, when it comes to pain scores and opioid consumption, that the paravertebrals are superior to the ESPB blocks for post-operative analgesia after non-mastectomy breast surgery. So in these types of patients, the paravertebrals seem superior both to serratus anterior blocks and to the erector spinal plane blocks. If we look at, again, the same for the ESP versus the paravertebral blocks, you can see that most patients in the paravertebral block have zero pain in the postoperative pain unit, and considerably higher median pain scores for the ESPB. And here you can see that it's even 4 times higher failure rate if you agree with this definition of failure in the ESPB group compared to the paravertebral group. Professor Comaker commented on that thoracic surgery now is performed less invasively, and if you look at the thoracoscopic surgery, which is becoming more and more popular, this is a quite recent publication from this Turkish group that prospectively randomized have looked at erector spinal plane blocks versus intercostal blocks or paravertebral blocks. And what they did show in this study was that the dynamic pain scores were significantly lower if you use the paravertebral compared to ESPB or intercostals at 24 hours. There was significantly lower morphine consumption during the first 24 hours, and the thoracic paravertebral block appeared to be preferable compared to the other techniques. So again, the paravertebrals are quite effective in this setting. If you then instead compare it to thoracic epidural analgesia, as we heard in the previous talk, the thoracic epidural is producing very good results. However, if you use a single injection paravertebral block, that led to the same similar patient satisfactions as if you use the thoracic epidural analgesia. And the authors conclude that at their institution, which is in Minnesota in the US, I think, that the single injection PDB is performed for most VATS cases owing to the shorter placement time and lower risk for serious adverse events. Then going over to this issue about multiple fractured ribs unilaterally, and Dr. Bosart has already summarized that quite nicely for us, I would say. I tried to find some prospective randomized studies, and I did find this from Journal of Trauma from 2009, and that shows that both thoracic epidural and thoracic paravertebral block behaved more or less identical. As you can see in this figure, there is no difference between these two methods when it comes to morphine requirements, length of stay in the ICU or hospital stay. But as we all know, of course, there is a higher incidence of hypotension in the thoracic epidural group. Otherwise, they're completely comparable in this study. As many of you know, I don't like case reports or case series from a scientific point of view, but sometimes they can be quite entertaining. And I couldn't help but share this case report from military medicine with you. We all have residents, and this can be interesting to bring in your back pocket when you have some lazy resident around. This anesthesiology resident were out biking, crashed and had multiple rib fractures, and were, of course, unable to perform his clinical duties, which didn't work well in the military medicine environment. So he got single paravertebral nerve injections at T6, 7, 8, and 9, and got a catheter, and again he was able to work, and he could take the catheter away after 18 days with no associated complications. This has, of course, no scientific merit at all, but it can just show you what the paravertebral catheter can do in the odd case. If you look at rib fractures in general, I have been unable to find any nice prospective randomized controlled trials, but there are two narrative reviews from our esteemed session chairman, Manoj, and in the one that is from 2011, his summary then is our preference tends to be the thoracic paravertebral approach, which I completely agree with. In a little bit later review from 2019, he's a little bit more cautious and says that it depends mainly on the available expertise and anatomical location of the fractures. And of course, if you have very, very posterior rib fracture, which is to me quite uncommon, I think that the ESP block, for example, could be effective for that, but anything in front of the mid-axillary line deserves some sort of other analgesic approach, being it a paravertebral or an epidural. I will end this talk on the same note and looking at traumatic rib fractures, but intravenous lidocaine is a quite interesting concept. And if you look at this study, published fairly recently in Regional Anesthesia and Pain Management, where they retrospectively compare thoracic epidurals with intravenous lidocaine, you can then see how they perform in this figure over here over 48 hours, and you can see that the epidural is performing slightly better, but that intravenous lidocaine is performing quite well, in fact. And in the situation where you don't have the possibility to offer the patient a thoracic epidural, then intravenous lidocaine may be very helpful to reduce the numeric pain scores, which I think is highly interesting. If we then just switch gears and look at the pharmacokinetics of lidocaine after bilateral ESP blocks that also were published recently, I was very surprised to see this pharmacokinetic profile of the ESPB lidocaine injection. This is the intravenous injection of 1 milligram per kilogram intravenously, and that we know provides quite decent analgesia and also have other favorable effects as reduced time of postoperative ileus if you have abdominal surgery. But if you look here at the profile of 3.5 milligrams per kilogram given in this bilateral ESPB, you can see that almost immediately, within 5 minutes, you have quite high concentrations than the intravenous injection. And you can also see here at the end that the terminal half-life is much slower than after the intravenous injection. So to come down to this point, if you follow this line, you will have an effect of this for some 8 or 10 hours. And these authors, who are then proponents of the ESP block, not as I am a skeptic, they conclude we propose the systemic analgesic effect of local anesthetics as a further piece of the puzzle to explain the analgesic effect of the ESP block. Well then, how can you get such a rapid absorption of the injected local anesthetic from the erectospinal plane? And this was clearly shown by Ortero, which is a group from Argentina, I think, from South America. They injected dye in this erectospinal plane in living pigs, and then soon thereafter they then euthanized the pigs and made dissections. And what they can see then is that within a couple of minutes, like 10 minutes, you have very, very highly stained lymph nodes, pre-aortic lymph nodes, but you have no staining here in the paravertebral space. So it is rapidly absorbed by the lymphatic system. So what happens here is that you will inject your local anesthetics here. It will get absorbed by the lymphatics, brought to the pre-aortic lymph nodes, and then go into the thoracic duct, and then go immediately into the superior vena cava. So it is very, very close to an intravenous injection. So that explains why you have such a rapid absorption and high initial concentrations of local anesthetic when you do an ESPB block. And this is my next to last slide. And this is hot off the press from Regional Anesthesia and Pain Management, where they had a prospective randomized trial comparing regular TAP block with intravenous lidocaine for renal transplant recipients. And they were looking at 60 patients in each group. And what they could find was this study found no difference in pain scores or persistent opioid use between the groups. So lidocaine is non-inferior compared to TAP blocks, which kind of tells me that the effect of TAP blocks to a large extent is due to systemic absorption of lidocaine or whatever regional anesthetic you use. So that is the end of my talk, and thank you so much for listening.